Hi, my name is Charlotte Howden and I'm the co-founder of the HT Collective. And today I'm joined by Neil Hardy, who is the Chief Pharmacist for the Hampshire and Isle of Wight ICB, which is the Integrated Care Board. So before we get started, lots to talk to him about today. I want to give you a little bit of a bio about Neil. So Neil is a senior pharmacist with extensive management experience across hospital pharmacy, community pharmaceutical services and community pharmacy. Since 1993, he has held senior leadership roles within a health authority, primary care trust, also known as PCT, clinical commissioning group, also known as CCG, and the more recent integrated care boards, ICBs. He was the Controlled Drugs Accountable Officer for Hampshire PCT. He's a registrant of the General Pharmaceutical Council and a member of the Royal Pharmaceutical Society. And Neil joins me now. Well, Neil, thank you so much for joining me today. I know we've got lots of things to discuss. But firstly, what is a chief pharmacist? Tell me all.
Okay, so as a chief pharmacist of an ICB, an Integrated Care Board, main responsibilities are around prescribing and to a degree community pharmacy. So from a prescribing point of view, responsible for the primary care prescribing budget and working with prescribers, GPs, PCN pharmacists and pharmacy technicians to improve the sort of quality and safety of medicines use, particularly in primary care, and also then working with colleagues in provider hospitals and community services, particularly around the interface where medicines, we know sometimes patients fall between the gaps there. So it's working with them to actually look across the whole system from the point of view of safe, effective and good value medicines use.
Amazing. But that's quite broad, isn't it? That's quite varied. But what's interesting is you use a few different bits of terminology that I think people listening or reading when this becomes an article as well will have heard of. But the familiarity is around the word pharmacy, but then we have community pharmacy, hospital pharmacy, prescribing in primary care, which you will mention. Can you just talk to us a little bit about the difference there, if there is a big difference?
Absolutely, yeah, no, and it has got a bit more complicated in sort of recent past. So everybody will be probably familiar with the community pharmacist and their team working in community pharmacy. So so you think of people of companies like Boots and independent pharmacies. Traditional role is around dispensing medicines to patients in the community, but obviously in recent years have moved into more clinical roles such as pharmacy first and being able to supply prescription only medicines for certain minor conditions. Also diagnosing and detecting people with raised blood pressure. So there is quite a big change to the community pharmacy role. Then you've got your hospitals and your mental health and community trusts obviously have pharmacists and pharmacy technicians working in those teams. And then with a very sort of varied role from sort of supply dispensing to very clinical, lots of independent prescribers in those hospital providers. And I guess the relatively new workforce is the pharmacists and pharmacy technicians who are working in either practices or primary care networks, PCNs as we call them. And there's been a huge increase in that workforce over the last probably about 8 years, because they're part of, you get very technical, but they're part of the additional roles reimbursement scheme. So basically PCNs were able to employ these professionals, and their role is very much supporting general practice and primary care around. So a lot of them will be prescribers themselves. They'll take on a lot of the long-term condition roles, so managing people with hypertension. They'll also be helping the GP sort out medicine shortages, of which there are quite a lot of medicine shortages at the moment. And yeah, again, to a certain extent, they are the workforce in primary care. So our role as an ICB is to support them in terms of the medicine safety, the medicine's quality and the value. So it's really exciting actually, because there is, we've really got a good workforce in primary care that actually is there to support patients ultimately.
Yeah, fantastic. So that sounds really interesting to me. It sounds like you were using the word workforce, but there's a big network of people there, isn't there,
Yeah.
specifically in primary care. So thinking about those different facets and the nuance of all that put together, the government has recently announced that it will be moving to a single formulary. So I'm really interested to know more about that. Obviously, especially around the fact that this announcement came within the renewed women's health strategy, which obviously I think we'll go on to talk about. But I suppose firstly, thinking about all the people you've just spoken about, what changes do you see coming, particularly for clinicians and prescribers, etc., as well as patients, as we move to this single formulary? Big question that, but I think you can take that one.
No, I think the single national formulary is very exciting, and actually I think it's to be welcomed. From my perspective, actually, patients, wherever you live in the country, the patient is the patient, the drug is the drug, and the condition is the condition. And actually, NICE has done a brilliant job over the last 20 years in terms of reducing what we would call postcode prescribing, particularly through their technology appraisals. So, that we are required, if they support a medicine, we're required to provide funding for that. And that's really helped. But as you know, there are medicines that don't have a nice TA, and then basically I decided locally, and there's something like sort of 300 formularies across the country. Quite a lot of them, like ours, are joint in terms of they're a system-wide formulary, so they include the hospital, primary care, community mental health services, and I think there has been, even with NICE approved medicines, there have been issues with uptake being variable. So I think actually the single national formulary is intended to reduce sort of duplication, make it really clear to local health systems that actually if this medicine should be available, it should be adopted, and patients should therefore have access to it. So I think the single national formulary is to be welcomed. It will obviously it's going to evolve, so it's not going to deal with everything straight away. And I suspect we will be asked initially, it'll have all the NICE approved medicines on it, and there'll be a really clear requirement for us to make those available, which we should be doing already. And I think it will expand, it will reduce a lot of replication in terms of people doing the evaluation, then having the discussion about whether it should be available. The really interesting is how it deals with shared care, as we call it. So at the moment, you'll be aware that if you look on a formulary, there's a number of different classifications, but typically it might be considered a red drug, which is only available in the specialist service, amber, which means it's started or recommended by a specialist, but then can be prescribed by GPs, or green, which means it's available to everybody. Yeah. And even, if you look at a particular product, and then across the country, you'll find that some places have it red, some have it amber, and some have it green. And I think if the single national formulary has an ambition to make that more rational and more consistent, which I think has got to be a good thing, hasn't it? It's got to be a good thing for patients, most importantly. But also, again, it's just mainly, why do we want 42 ICBs, or there's slightly fewer now, aren't there, because of their mergers, but having similar discussions, So I think there's a really ambitious an ambition to have this in place in 2 years' time. In fact, now just over a year now, but it will evolve, and it'd be really interesting to see. But as ICBs have smaller teams, we need this to be done once. NICE absolutely proves that you can do something once, do it to a high quality. You really consider the evidence, and you consider the cost effectiveness, and then make a pronouncement. So I think the only other thing about single national formulary is I think it's intended to reassure pharmaceutical companies that when a drug has got a positive NICE approval, then the drug will be used. And I think that's perfectly reasonable. They've invested all that work into developing it. Yeah,
and that's a really interesting point, because one of my next question actually was going to be in terms of, you've already mentioned the postcode lottery being a real challenge because you don't or we don't have a single formulary. But something else that I've witnessed in my career so far within Pharmacist is companies who do invest in drugs for pregnant women, which is quite unheard of, isn't it? If you're going to go into, you know, research and developing new drugs, pregnant women tend to be avoided because there is still that taboo and stigma, very sadly, due to the legacy of thalidomide. But if they are going to do that, the reality has to be there has to be some reward for that, and that is that once this drug is available, whether it's just a licensed drug or actually has been developed specifically for pregnancy, it is then able to be quite quickly and rapidly, maybe might be too strong a word, but routinely rolled out across the country so it is available to everyone. I mean, would you agree with that? I think you did just earlier, but
yeah, I would. It's really interesting, and you're right. Actually, there's a lot. You know, well, clearly the pharmaceutical industry is really important to the country from a sort of economic and employer point of view. And you know, it isn't. I don't think it's my role in ICB to try and block a medicine that's got national approval. You know, there are obviously, you know, we can't ignore the fact that there were cost impacts, but that's the whole point of having a national system for approving, and they should be made available. And you're right, actually. I mean, another good example would be antibiotics, where actually, because you tend to give the patient a course, then it's not going to be as many used as something that's treating a long-term condition. So, you know, government do all sorts of clever things with the industry to actually incentivize the development of things like antibiotics, which are really important, clearly, and you know, make them available, and yeah, support that sort of innovation, support that research agenda. And actually, I hadn't really, I mean, I confess to say I hadn't really thought about it, but you're absolutely right. You know, medicines in pregnant women is not something that people do lots and lots of research studies on, is it? So it's really important that when the medicine's available, then actually it is that then supports industry to develop other medicines. That's the key bit, isn't it?
Absolutely, yeah. And I think obviously you've touched on Zombia before, and that's a really good example. Whereas all the medications that are currently available via alcohol guidelines to women suffering from hyperemesis, none of them are licensed in use for pregnancy at all. The only drug that is Zombia. And what was quite an interesting experience was, you know, women being prescribed drugs that are not licensed for use in pregnancy over one that was, because quite simply, you know, the formulary said no. And that was a really difficult thing to explain to, you know, women in quite dire, desperate need of help and support. And I should say, and I always make this very clear, even though those medications weren't licensed for use in pregnancy, they were still safe. I think because that can sometimes worry and confuse people. They were very safe, decades of being used. So, you know, we have that data of them being used. But it was just the irony of, you know, we've got one here that is licensed for use in pregnancy, which is great. Someone's taken that investment and that time to get their license, and then it's not available. So yeah, it was a really very frustrating situation.
Yeah, no, absolutely, because getting a medicine licensed is not an easy or inexpensive process. And you're right. I mean, you know, there's because of the fact that people don't do the studies, and there are more medicines that are unlicensed. It's the same with treating children. You know, there's lots and lots of medicines that are unlicensed or off-label, used in the treatment of children, because no one has ever done the studies in that age group. That said, I think there is also, as you quite rightly say, if you have a licensed medicine, then it seems sensible to have that as an option, along with no one's saying you shouldn't use medicines that actually have got a good evidence base despite not being licensed, but having, and that's the other thing about it's sort of linked to the single national formulary, is the fact that there is a plan that the MHRA, who is the organisation that approves medicines for use, and NICE will actually work much more closely together. Because what we get at the moment is that the MHRA provide a marketing authorisation, so effectively license that medicine for use in the country, and then it might be another 18 months before NICE actually look at it from a cost-effective point of view, and that must be very frustrating for clinicians, and not good for patients who may benefit. So there is an ambition and a plan that the NICE process and the MHRA process will be much more sort of in parallel, which I think is again really positive.
Yeah, definitely. Well, on that actually, so we've spoken about postcode lottery. That looks like another advantage to having a single formulary. Are there any other advantages that you foresee from this? I'm sure there's lots, but specific perhaps to women's health or the things we're discussing today, that you think this is a really good ambition that we get this done in the next 2 years?
I think yeah, I've sort of, there's definite advantages to doing it once and doing it well, and having, you know, the sort of the process that NICE use is something that you could not replicate in a local health system. So actually looking at the evidence properly, getting the specialists involved properly, getting patients involved. Let's be clear, you know, it's really important that patients are involved as part of that evaluation process. I think the other thing that I would hope is that because it's a national formulary, its priorities will be guided by the NHS national priorities. And you're right, and I probably get the title of the document, but the review of women's health, you know, that's a national priority. There's a document that says these things need to happen. So actually to link that to having it in the formulary is really positive, I think. Because otherwise, you know, I mean, formularies vary hugely. Some try and cover every single medicine. And that's probably more about saying what's available on a shelf, frankly. You know, what does the hospital stock? But actually, we mustn't lose focus on those big, important national priorities. You think of things like cardiovascular disease, pregnancy, I think actually absolutely fits in that frailty. So I would hope that the prioritization process for what goes on the formulary is linked to the bigger prioritization process about what actually, you know, what actually is really important to the NHS.
Yeah. Changing direction a little bit and talking now more about Pharmacist. From my own journey, I'll be completely honest with you, Pharmacist didn't feature in my journey with Pharmacist. Although obviously they did, I was eventually prescribed medication, but my husband had to pick that up for me because I was bedbound. So I never actually, you know, met anyone who was giving me this life-changing drugs. And with HG, very quick, timely, effective treatment early on is really, really necessary. So I suppose I feel like this question you might not be able to answer, but how could pharmacy influence a better approach to early intervention for pregnancy related conditions like HG, where normally it's going to your GP or potentially midwife, depending how pregnant you are? Because I would love it, Neil, if we could walk up to a counter one day and say, I'm pregnant, can I have some Zombia? But we're not there yet.
No, and I think there's it isn't, I mean, I'm not a community pharmacist, so I have to be, I'm wary of sort of speaking on their behalf, but
of course
I think there is one of their really important roles is signposting patients, and that's you know, that's very true of the sort of minor conditions and with their new clinical role. So as well as being able to prescribe where it's appropriate, they need to recognize red flags and refer patients accordingly. And I guess in this situation, it would be, I think I absolutely agree, it would be great if the community pharmacists and their teams, because again, it's not always going to be the pharmacist you speak to, but their teams actually almost recognise some of the red flags and say, you really need to see your GP, or you really need to speak to your midwife about this. This is not, you know, normal pregnancy sickness. This sounds like it's actually really serious. So I think, and maybe we could do it because we both live in Hampshire, we could actually look at some awareness for training, and so that actually pharmacists feel a bit more skilled to signpost, and when it's not so severe, be able to give advice. But I think that's probably their key role, because lots and lots of people go into pharmacies, they seek advice on all sorts of conditions. Some of those are going to be people who are pregnant, and therefore, you know, obviously in the hospitals, you know, the obstetrics teams will have pharmacists who are real specialists, but that's going to be you know, that's dealing with a minority of patients at a certain stage, isn't it? But I think, you know, awareness raising is really important, and being able to signpost patients, sometimes support patients to actually say, you know,
Yes.
you are allowed to go in, you know, I would encourage you strongly to talk to your GP, you know,
Yeah.
don't suffer in silence. It sounds like you need help. So, yeah,
Yeah.
I think there's some work can be done. And there might be other
Yeah.
areas that have done it great and we can find that out, you know, so.
Yeah, definitely. I mean, yeah, I think that sounds fantastic. And actually, in a lot of the advocacy work I've done so far, it felt like there was a lot of other people to concentrate on first. So, for example,
Yeah.
midwives felt very not confident at all to support with pregnancy sickness because it's not something necessarily that would feature in early curriculum. It was very much something that would be pushed to primary care, so they didn't feel very confident. GPs as well with prescribing. So pharmacy was almost on the periphery but you're right, because more people are going to go to pharmacies. That's the way that the government, particularly this government as well, is pushing people to go there first before making an appointment. Go and, you know, pharmacists train for longer than doctors, don't they? Or am I just making that up?
I think they don't. So yeah, I think they get slightly. But they do a 4-year. They do a 4-year. Pharmacists now do a 4-year undergraduate course, and they come out as prescribers. That's the key thing. As soon as they're qualified, they're prescribers. So you're right. There is potential to actually think we will have, you know, in the near future, prescribing pharmacists working in community pharmacy who will be able to be commissioned to actually provide services which include prescribing of prescription only medicines. So yeah, it's exciting. I say I don't at the moment. I don't think they would probably think that's not, you know. And same with the PCN pharmacists. They wouldn't be thinking I deal with pregnant women with hyperemesis. Yeah, and it's interesting actually. It goes back to that conversation about medicines being licensed for use, because actually as a prescriber, you know, you're taking both professional and legal responsibility for writing that prescription and the adverse, and actually having a licensed treatment actually supports that decision. If you're prescribing either something that's unlicensed or off-label, then that probably does put more responsibility on the prescriber to actually know that there is an evidence base and supporting that. So actually, by the fact that it is licensed, you can say, well, it is licensed for this indication, and I was prescribing in line with the license. So
yeah, absolutely. And all the guidelines, the most recent guidelines for hyperemesis were alcohol guidelines in 2024. They were published and released. So but it still takes time, doesn't it? That was 2 years ago to kind of filter down. I mean, we're a huge network of primary care and secondary care and lots of other networks within healthcare in England. So it does take that time, but yeah, the more conversations we have, the better about it, which is great that we're talking today as well. So so look, my last question, it sounds like from what we've spoken about today, I when I heard the announcement, I was very excited about a single national formulary. I think it's a good thing. I'm sure there's always going to be challenges. There's always going to be things that will evolve from this decision that perhaps we weren't aware of or what have you. But how ambitious is it to get this online ready to go in 2 years, do you think? And what do you think needs to be done to hit that target?
I think it's ambitious, but I think it's absolutely possible. But what it won't do, so you know, and we've had for many years a requirement to put all NICE approved medicines onto our formulary and to publish our formulary, and we do both. There's sometimes implementing a NICE, increasingly actually there's delays around implementing a NICE technology appraisal, not because of the medicine and the cost of the medicine, but because of the infrastructure required. And that might be, you know, that actually the patient needs to see a particular specialist. And you know, if the waiting times are such that actually, particularly patients who are not under a specialist at the moment because they're on the best available treatment, there's no advantage to seeing the specialist, but then of course when a new treatment comes in, they need to come back into the system. So I think as long as the single national formulary focuses on it will starts to focus on the new medicines, NICE approved, innovative, nationally supported. What it doesn't want to get down to is having the sort of liquid version of every single medicine because local hospitals and local primary care can work that out themselves. I mean, if a patient can't swallow a tablet, then it's obvious that they should have an alternative formulation, and we don't need a national decision on which brand of that liquid we should keep. So I think as long as they focus on the big priorities, and I think that is around innovative medicines, NICE approved for the hospital, things like drugs that are supported through the Cancer Drugs Fund. I think they will get there. I think that's possible. The shared care and the classification is going to be, I think that's going to be interesting and slightly tricky, because it will be changing what's currently happening in certain areas. So that might take a bit longer. But again, you know, it's really important from an access point of view. I mean, the shared care should be made on the basis of safety, clinical appropriateness, and what's best for the patient, I think. And it shouldn't be made on the basis of who's paying for it. That's because we're all paying for it. We pay for it either way, don't we? The NHS pays for the drug wherever it comes from, and therefore actually it should be a combination of, you know, if this is a very specialist medicine, then it's probably better that it stays with the specialist who has the knowledge and the clinical responsibility. But it should be on that basis. But we must never we should never forget patient access, really important, because if it's not easily available, then it's not available, is it? So
yeah, absolutely. Just on that then, because even though I said that was the last question, because that's brought up a really good example. So I was under specialist care in a hospital, so secondary care. I was prescribed ondansetron, which is a second-line medication for hyperemesis. Obviously, it's off-label. It was life-changing. I went home, then spoke to my GP. They wouldn't prescribe it for me. So I then had to go back into hospital. Luckily, I had an incredible obstetrician who rang my GP and said, "Don't be ridiculous. Prescribe this. She can't keep coming into my service. I'm at the hospital. She needs to stay at home. She's severely unwell. Just why wouldn't you prescribe it?" And they were kind of having that kind of face off, I suppose, as to, well, you prescribed it in specialist care, so it needs to stay there. But the reality for me was my hospital was a 45-minute drive away, and I was vomiting 30 times a day. So I wasn't able to keep doing that, if that makes sense. So my obstetrician solved that for me. But I hear so many women talk about they don't get that lucky. They don't have someone advocating and picking up the phone and kind of, I won't repeat what she said, but she was quite strongly worded with the GP on the phone. Let's put it that way. So what do we do about that when we think about this national formulary?
Yeah, I think I can sort of see both sides. So I can perfectly understand the GP saying it's a specialist drug, it's off-label, it's not something I know about. And actually all I'm really being asked to do is to actually provide it because of the lack of convenience. And I absolutely get the fact that you say it's not. I think there's two things. I think good shared care involves the transfer of a really clear plan that says, actually, these are the bits that I'll do, these are the bits you'll do. And if you need support, you can access the specialist easily. I think that's where shared care guidelines should help. I think the other thing that really will help going forward is easy access to electronic prescribing in hospitals, which is definitely happening now. So, you know, I think, and so actually, if it's decided that, and this is probably something the single national formulary will do, if it's decided that this medicine should stay with the specialist, even though the patient's, as you say, back home, then actually having access to electronic prescribing that goes to your local pharmacy solves the problem. The GP doesn't need to be involved then, and with certainly locally and across the country, there are systems in place now that allow that. So that would solve the problem actually, because it would still be under the right. The specialist would be prescribing. They know all about the medicine, but actually, from your point of view, somebody doesn't have to get in the car and drive 45 minutes just to pick up a prescription, probably, or the medicines. You know, it can actually be sent through the same system as primary care, landed with your preferred pharmacy. So that's a really good example where actually shared care will change over the next few years anyway, because you're right. Sometimes the decisions about whether or not it should be amber are probably pragmatic, and well, actually it's
Yeah.
so much easier for the patient to be able to obtain it if the GP prescribes it and it goes on the list of other medicines. But actually everyone should be able to prescribe electronically. So yeah.
That's brilliant. I love what you said there. It's just a really good shared care plan and decisions made on who's going to do what. And I think if that can happen quite quickly, what happened to me wouldn't have happened, and many other women. So I think that's a great bit of advice. And again, about the electronic ability to prescribe electronically will be a game changer as well. Neil, thank you so much. It's been incredibly interesting speaking to you. And I think it kind of, just us two speaking, I've got lived experience. Obviously, you're the chief pharmacist. You can explore other avenues that I don't necessarily get to think about, and vice versa. So yeah, I really appreciate your time today.
No problem at all. And ditto the other way, actually, because, you know, I haven't got lived experience, and clearly, and actually we aren't as good as we should be in terms. I'm talking to our patient participation group this afternoon about medicines, and you know, and it's actually really interesting because I probably think I know what the priorities are, but it's very different. You know, a lot of it is very, as you say, I mean, that's a beautiful example, isn't it? Actually, it's all great. I don't care who prescribes it, but I just need to get hold of the medicine, isn't it? And,
yeah.
actually, if I can, you know, and you were probably lucky to have a husband with a car that could actually drive there.
I was. Yeah,
you know, but
I was.
actually, I didn't feel lucky at the time because you're feeling awful, and you know, but
no, yeah, no,
so, yeah.
and you're right, and I think that then widens out. So if you're speaking to a PPI or PPIE group this afternoon, that's great. And I'm not quite sure what you're talking about, probably not hyperemesis, but no. I think it's exactly those conversations that make you look at the realities of these conditions.